Hello, and welcome to a discussion on healthcare access during the coronavirus pandemic in New York. In today's discussion, we are featuring Carrie Tracy from the Community Service Society of New York.
I'm Carrie Tracy. I work at the Community Service Society's Health Initiatives Department, and I'm the Senior Director of Health Initiatives. So I'm lucky because I get to work on all the wide variety of things that the Health Initiatives Department does. And so we work on making sure that everyone in New York State has access to quality, affordable healthcare. And we do that by focusing a lot on coverage and helping people get insurance or helping them use insurance, or if they can't get insurance, helping them get access to affordable care. Out of that work, we're able to help people one-on-one, but we also figure out what's going wrong. What are the problems that we see people having over and over again? And then we're able to do deep dive research projects. And so one example of this process is that a couple of years ago, as we were looking at our data for our direct service projects, we noticed that there was this huge spike in the number of people who were having trouble with medical debt and bills they couldn't pay. So we asked, why is that happening? And we started doing research, and we started identifying some common problems, some trends, and also some solutions that had been tried out in other states, other places that we thought might work for New York State. And so we wrote some research, deep dive research projects, and then using those on the ground experiences and the research, we work with a network of organizations, Healthcare for All New York, that's a coalition of consumer groups working around the state to help advocate for solutions. So we lobby legislators and regulators and the governor, and we talk to people about what's going on and what kinds of solutions should be enacted. And then to come full circle, once those solutions are enacted, when a law is passed, we're able to bring that solution back to our advocates, right, who are working on the ground, and so that they can get out and educate providers and patients and insurance companies and make sure that all the new laws and regulations are in place and are working for people.
Speaking of working on the grounds, what is CSS hearing from patients in New York about healthcare cost burdens?
So one common problem that's been a problem for a long time that really broke through was uninsurance. The Affordable Care Act was amazing. It's such a blessing for New Yorkers, and New York State implemented it to the fullest. So we were able to bring our uninsurance rate down to 5% before COVID hit. So a lot more people had insurance and it was more effective. But we still had 1 million people in New York who were uninsured for various reasons. And one trend that had been going on long before the ACA, but has continued, kind of accelerated a little bit, is that even people who have insurance have higher deductibles, higher cost sharing, high co-pays. So even if they're insured when they go to the doctor, they end up with bills that they might not be able to pay. So insurance status was one problem that we saw getting worse. Another was hospital inequities. This was something that people on the ground had been talking about for years, but the system had kind of creaked along, but COVID really broke it. And so my organization, my colleagues at CSS wrote a report last June, kind of examining this issue. We'd been working on healthcare funding for a long time, but in June, after a couple months of COVID in New York City, we did some research, and what we found was that there were these huge inequities between where the hospital beds were and where people needed those hospital beds, right? So in Queens, it was the epicenter of the epicenter, right? There were 22 cases at that point for 1,000 people, but only 1.5 beds per 1,000 people living in Queens. Whereas Manhattan, people were able to work from home or leave the city entirely. There were many fewer cases. There were 12 cases per 1,000 people, 12 versus 22, but 6.4 beds per 1,000 people rather than 1.2 in Manhattan. So we know for many, many years, the resources in our healthcare system have gone to some hospitals and not to others. Part of that is our hospital fund or our insurance funding, right? We don't have a single payer system like the New York Health Act that would pay every hospital the same exact amount for every episode of care, no matter who you were, right? Right now we have this system that's broken up in a million different ways. And so people with commercial insurance, the hospital get paid the most for treating them. And then Medicare, and then Medicaid, and then people who are uninsured have to struggle along and try to pay it themselves. And people of color and people who are low income are most likely to have Medicaid or be uninsured. And we have a really segregated housing system, right, in our country. And so hospitals that are located in low income communities or communities of color are more likely to get lower reimbursement rates. They're struggling to stay open. And so around the state in the last 20, 30 years, we've seen hospital closing after hospital closing concentrated in communities of color and low-income communities. And so when COVID hit, the people who were hardest hit were people who were essential workers, people who lived in crowded housing, people who couldn't leave the city when it hit. And those were the communities that also were missing hospital beds or had hospitals that were really under-resourced to begin with and had a hard time dealing with. So that was another real crisis that we saw. And the third was medical billing. Like, we've been working on medical billing for many years. All of us saw that this was an increase in crisis. More and more people were having trouble with it. But the pandemic really, again, added this huge crunch to it. So people were afraid to go to the hospital if they had already had a bad experience with a medical bill, right? So they got sicker and sicker before they went. Billing offices closed. You know, during the pandemic, the hospitals weren't able to keep their billing offices closed, but those bills are automated. So the people were getting these bills at home, losing their jobs, having less income to pay the bills. But when they tried to call the billing office to resolve the bill or say, I don't think this is my bill, nobody could answer the phone. So we had this like increasing pressure on people. What we found before the pandemic was started was that out of like the 200 hospitals in the state, 139 hospitals were suing some patients, but 25 of those hospitals were suing 93%. Were responsible for 93% of the lawsuits. And while there was a median amount of $1,900 for the actual hospital bills that were being sued for, but once these cases had, gotten to a judgment, people were being asked to pay $2,300. So if you didn't have the money for the $1,900 bill, you weren't going to have money for all these extra interest and court fees. But when you looked at the context of, is $1,900 going to break a multi-billion-dollar hospital budget, or is it going to ruin somebody's financial future? We saw that hospitals were really quick to sue people. And then also New York State has this indigent care pool. We've been working on this for many years, state and federal funding over $1 billion to help hospitals that disproportionately serve folks with Medicaid or people who are uninsured, right? Because we know that those hospitals are struggling to keep the doors open. So New York, instead of focusing the money on those safety net hospitals, they were giving every hospital in the state a piece of this money. So what we found was that the top 10 hospitals that were suing patients got $55 million more in just 1 year than they reported themselves they spent on people who they gave discounts for their care. So they were getting this huge windfall of money from the state to cover people who needed financial assistance, but they weren't processing people or giving them the financial assistance. Instead, they were sending them for lawsuits. So when the pandemic hit in January this year, we thought, well, hopefully when the billing offices closed, when people lost their jobs, hospitals stopped suing, right? We looked at it. But what we found was that 55 hospitals continued to sue patients. They sued nearly 4,000 people. During the pandemic, between March and November, they were getting billions of dollars in federal CARES Act funding, right? That all this money was coming into the state to these hospitals. But the lawsuits continued. People continued to get default judgments, which meant they either didn't know they'd been sued or they couldn't afford a lawyer to help them with it. And we saw that there was disparate impacts in communities of color. In several of the medical debt hotspots around the state, we saw that people of color were more likely to have these medical debt problems. And in Albany County, 26% of people of color experience medical debt problems, whereas 10% of white people in the county had that issue. So then we did a follow-up just a couple months ago in March to look just in Albany at that hotspot and see what was happening. And we saw that, again, there was this disparate impact by race and things like wage garnishments. Hospitals were garnishing wages of people who worked at Walmart or retail and food, even people who worked at their own hospitals, they were suing for that. So each of these things were things that have been going on for a long time. They've been problems we've been working on, but COVID really brought it out into the public more and also just really stressed people out a lot more.
For underserved communities and for people battling medical debt, especially our lower income communities, the working poor, and people of color, what kind of safety net policies are currently in place that people should be aware of?
First suggestion is CHA and Navigator. So call our toll-free helpline. It's 888-614-5400 because we have trained advocates on our helpline and also in every county who can help people who qualify for insurance to sign up for it and affordable coverage. Like, there's a lot of people don't realize how cheap the insurance can be, including free. And we also are able to help people apply for hospital financial assistance, or we have experience negotiating with doctors who don't provide financial assistance to help bring down the debt to something that you can afford or get a payment plan. So New York State has this law, has since 2008. Advocates fought really hard to get it, the hospital financial assistance law. And it said that any hospital in the state that gets this indigent care pool funding, this $1 billion in funding, which is every hospital, has to offer their patients financial assistance. And this is also part of the Affordable Care Act. It also included requirements that hospitals provide financial assistance. So if you're uninsured and your income is up to 300% of poverty, you should be offered by the hospital the ability to apply for financial assistance. Or if you have insurance, but it's not covering the service, some people who have insurance, hospitals also offer discounts on their deductibles and copays, and many hospitals go higher than 300%. So it's something that every hospital in the state is required to have this financial assistance application. It should be simple. It should be on their website. When you go to the hospital, they should tell you about it. It should be on all the bills. There should be information. Every hospital in the state is required to have an application and a policy, and they're required to put it on their website where you can find it. They're also required to have staff who can tell you about it. There should be signs up in the hospital and waiting rooms and the emergency room. It should be listed on bills, the fact that there is financial assistance. They should have staff who can help talk you through the application. It's supposed to be very simple. In reality, our experience is it's not always that simple. Even hospitals that say that they're covering people up to 600% of poverty, or they have these really liberal policies, they're not always getting the word out to everyone. And so sometimes people will say, I called the hospital and said, I can't afford this bill. And they said, too bad, you have to pay it. And that's how I ended up in court. So that's a problem. So we want to get the word out to everybody. This hospital financial assistance is the law. Every hospital in the state is required to provide it. And people as community health advocates have helped innumerable people fill out these applications and appeal denials and work with the hospitals to get them that help. So please give us a call, 888-614-5400 if you need help. There have also been a number of things that New York State and the federal government have done, even just in the last year, to make coverage more affordable. So at the very beginning of the pandemic, New York State acted to have emergency Medicaid, which covers people who are undocumented and qualify for Medicaid by income, but don't qualify for full Medicaid because of their immigration status. Emergency Medicaid covers COVID and COVID-related services. During this legislative session, the governor proposed, and the legislature expanded on, getting rid of all the premiums for the Essential Plan. And the Essential Plan is part of the Affordable Care Act. It's called the Basic Health Plan in the ACA. And New York is one of only 2 states that were smart enough to enact this program, which is amazing. So people whose income is just too high to get Medicaid, up to 200%, which is 200% is hard to pay a premium for insurance. Anybody who gets the Essential Plan right now pays no premiums at all for basic medical care, and now also for vision and dental. And if you have that care, you'll have no cost sharing for vision or dental, but some small, modest cost sharing for regular medical care, but free preventive care, just like the ACA. Every insurance policy has to offer you free preventive care under the ACA. So the EP is a great deal. It's great coverage, and a lot of people still don't know about it. So call your Navigator. And also New York has had open enrollment ever since COVID hit. You've been able to go to the marketplace at any time and apply for insurance for the first time or renew your coverage. They've been automatically renewing people's Medicaid coverage and Essential Plan coverage so that people didn't sort of fall through the cracks and end up uninsured at all.
Thank you so much, Carrie. And I want to revisit one of the terms that you've used, which is the Navigator program. What is the Navigator program and who qualifies for it?
For every Obamacare marketplace, ours is New York State of Health, is required to fund community-based navigators. And so they're community-based organizations in every county of the state that the state gives a grant and then holds trainings. You have to go through an initial certification training to become a navigator. And then every year, once you're a navigator, you have to do a number of trainings to make sure that you're up to date on all the changes and policies and stuff. So navigators are trained and certified, and they're free. You should never have to pay a navigator. And they're completely unbiased. It's not like, some brokers might get a commission depending on which insurance company they put you in. Navigators, it's free and they don't get any commissions. They're completely unbiased. We're actually not allowed to tell you which plan to pick. We can tell you the difference between plans, but we can't say you should pick this one or that one. So it's very independent.
Thank you so much, Carrie. I heard you mention earlier on about the New York Health Act. I think this is a good time for you to do a little bit of a deep dive into what the New York Health Act is proposing. Do you mind explaining what the New York Health Act is?
Yeah, so the New York Health Act is New York's single payer legislation. So this, under the New York Health Act, every single person in New York State would get the same insurance. Regardless of their income, where they worked, everybody would have the same insurance and there wouldn't be any premiums. It would be paid for with payroll taxes and other sources of funding from the state. So you wouldn't have to pay a premium every month and your care would be free. It also would mean that every provider gets paid the same rate instead of some hospital, instead of in some, as I said, some hospitals get paid more or less depending on who comes in their door. So it would help to stabilize the healthcare system and make sure that everybody gets great quality care. And it would mean that everybody in New York State, regardless of your immigration status or your income, where you live, you would have the same high quality healthcare. And it seemed like a big dream a long time ago. And each year, more and more legislators are signing on to the bill, but we still need to do a lot of work because even though there are a majority of legislators signed on to the bill, it's still not getting a vote. There's still some hesitation. So we still need to keep pushing. We need to keep talking to, even if your legislator has signed on to the New York Health Act, you need to talk to them and ask them what they're doing to make sure that the majority leader and the speaker bring it to a vote and make it happen. And you need to talk to Governor Cuomo and tell him why it's important to you as well. So that's a program that would solve a lot of different systemic issues. And so the Community Service Society and Healthcare for All New York support that. A second thing that we're working on is the Patient Medical Debt Protection Act. So in this work that we've done around medical billing and looking at lawsuits, we identified a number of problems that we saw people having. And so we solved a couple of things, like we shortened the statute of limitations that a hospital could sue you from 6 years to 3 years. And this year I'm going to talk about, there's a fix for interest rates, the amount of interest the hospital can ask you to pay once they win a case against you in court, how much interest they can ask for. But there are other things like getting rid of facility fees, which are a fee just for walking in the door, not related to any care. That's a new trend in billing. A one visit, one bill. So right now you go to the hospital for, you have a heart attack, you go to the hospital, and we've had patients, come see us and they've got garbage bags full of the bills, right? You get a bill from the lab, a bill from the pharmacy, a bill from the radiologist, one from the anesthesiologist, one from the emergency room. And they just keep coming over and over again. And you can't tell. People are like, I'm sure I paid this bill, but I don't want to go to court, so I'm going to pay it again. And it's really confusing. So we think when you go to the hospital, you should get one bill that has all of it on it. And so you can read it and understand it. So that's what the Patient Medical Debt Protection Act is. We're also working on the indigent care pool. I talked about, last year, the state directed more of the funding to safety net hospitals, stopped directing some of it to hospitals that don't do any financial assistance, but we think that it's time to take it another step and really direct that funding to the true safety net hospitals that serve disproportionate numbers of people who have Medicaid and are uninsured. So there's still work to do on that. There's still work to do on the hospital financial assistance law. Like I said, the law says the hospitals have to tell people about it, but a lot of people aren't finding out about it. There are still some parts of it that are clunky and make it difficult for people to apply. Questions about whether they can look at your assets, they shouldn't, things like that. So we want to fix that up. But the three things that people can work on right this minute are, the first thing is rate review. In 2010, New York State passed a law that said that if an insurance company wants to raise the rates from one year to the next, they have to submit an application to the Department of Financial Services. They have to lay out exactly why they deserve to increase your premiums this year. They have to provide a ton of information. And that law, unique in many states, gives consumers 30 days to weigh in on this decision. So if you have insurance and your carrier's trying to raise your rates, you should have gotten a letter from the insurance company saying, we want to raise your rates. But you can also go to the Department of Financial Services website. They have all the information. You can just enter your own experiences, and the regulators really, Department of Financial Services really reads every one of those comments, and they take that into consideration when they think about that. And also we have information about that on the HIC Fannie website. A second thing is the certificate of need bill. So I talked about how hospitals in many neighborhoods that are underserved already, hospitals are trying to close. Hospital systems will buy a hospital that's not doing very well and then shut it down. Or they'll say, we're going to close the maternity ward or the emergency room, things like that. It has a huge impact. So when they want to do that, they have to go to the state body and apply for this thing called the certificate of need, and they have to get permission to do that, or to open a hospital or to add a new ward. So what we're saying in this legislation, which is Senate 1451A, said that if a hospital wants to do that, to close a hospital, downsize it, open a new one, they should put together a statement of racial equity impact. So, like sometimes when somebody wants to build a new apartment building, they have to do an environmental impact statement. They have to say, this is how this building will affect the impact. Well, we want to know, if you close this hospital, where are your patients going to go? Is there another hospital close enough that people can get the same quality of care that they got? If it's a maternity ward, you want to close the maternity ward, how are people going to get to the nearest hospital? And how's that going to affect racial disparities in your community? So that passed the House and Senate, or the Assembly and the Senate. And we're waiting. The governor has to request them to send it to him, and then he can sign it. So we want to get the word to the governor that this is a really important bill. We want this signed. And then the other bill that has passed, and we want to make sure that the governor requests it because it passed the Assembly and the Senate, is related to interest rates. And it would lower the amount of interest that if someone has a consumer debt, and that could include medical debt, education debt, credit card debt, if you don't pay the bill and you get sued, once the company, whatever company has a judgment against you, right now they can charge up to 9% interest. It lowers it to 2%, which is much more reasonable, especially for nonprofit hospitals. They shouldn't be charging this commercial rate of interest. So in all of these campaigns, it's important to ask who's being affected, even if it's not the intended effect. What are the impacts of all of these policies on people and on our healthcare system, and on who gets access and who gets, what's the quality of care that people get, not just, getting care, but are they getting the care that they need? And is it equitable?
What would your advice be to patients to ensure that their voices are heard, whether it be today, tomorrow, the next week, or the next year, in terms of helping them to improve their ability to access quality healthcare and to gain access to care without fear?
Yeah, tell your story. That is the most important thing people can do, is get the word out. Tell other people in your community, like maybe your neighbors or your family members, other people don't know that this affects you and they think this isn't a problem. I don't care about this issue. And maybe your legislators think that. Maybe they think none of my voters cares about this. I'm not going to work on it. We need to get the word out to everybody. This is a problem. This is how it affects people, and we want to change it. So we have a number of social media accounts. We the Patients is a digital organizing campaign run out of the Community Service Society. And so we have social media accounts at We the Patients New York, and also Healthcare for All New York has social media, and we have websites, www.hcfany.org or wethepatients.org. You could go to any of these websites, or cssny.org. All three of those websites and social media handles are part of our organization. And if you go to any one of them, you can get plugged into the campaigns that we're doing to move all these policies.
I appreciate you sharing your expertise and look forward to talking to you soon. Take care.